welcome everybody to Journal Club. Today, we're honored to be involved from the University of Arkansas for Medical Sciences. We have our theme today is patient selection and predicting outcomes in spine surgery, presented with 4 journal articles from the resident staff of our department. I'm also honored to be joined by Dr. Glenn Pate, Richard McCarthy, and David Bumpus as our staff orthopedic and neurosurgeons who will join us as moderators. And so thank you very much to Seattle Science Foundation and the physicians at Texas Back Institute and the others for giving us this opportunity to be involved in this fantastic virtual journal club. So thank you once again. And we may start with our first paper. Dr. Patrick Paulus will go ahead and present our first article. Go ahead, Patrick.
My name is Patrick Paulus. I'm a PGY7 here at UAMS in Little Rock. I'm presenting a paper titled An Analysis from the Quality Outcome Database, Part 1, Disability, Quality of Life, and Pain Outcomes Following Lumbar Spine Surgery, Predicting Likely Individual Patient Outcomes for Shared Decision Making. This paper came out in 2017 out of a couple of groups, mainly out of Tennessee, Vanderbilt, South Virginia. So to set the stage a little bit, the introduction, the authors point out a couple of concepts. One is spine surgery is expensive. So they point to this 2011 study that indicated that the greatest proportion of U.S. hospital costs are attributed to spinal fusions in the U.S. And then you juxtapose it with the second point they make, which is there's a lot of concern about exactly how much we're getting from that endeavor. They point to a study that indicated 25% of spinal diagnostics or therapeutic spinal interventions are unnecessary or ineffective. So more and more, because of these two concepts, people are looking at whether we're getting enough out of these expensive spine surgeries and looking at patient-reported outcomes. So it's important for us to understand what they are, how to assess them, and how to predict them and control them. Another concept that they bring into light in predicting patient-reported outcomes is how we can use them to have shared decision-making. So whenever we talk to a patient about a complex surgery and we're able to boil it down to what the probability of them having a successful outcome, this can help kind of set realistic expectations as well as breach the gap in terms of getting them to increase their own probability by changing their behavior and changing modifiable risk factors. So essentially they created a mathematical model to predict these patient-reported outcomes based on data taken from a multi-center prospective registry, the Quality Outcome Database. They took patients out of a 2-year period and concentrated on lumbar spine surgeries for degenerative disease, and were able to obtain about 7,618 patients. The patient-reported outcomes were taken at baseline and followed at 12 months. For this model, the variables that they used included things that we commonly see in demographics in a lot of literature papers: age, sex, BMI, comorbidity status indicated by the coronary artery disease, ASA, whether they have diabetes, and of course with spine osteoporosis. The patient-reported outcomes were used as variables for baseline, included the ODI, the numeric score for leg and back pain, the quality of life, which was captured in the EQ5 questionnaire, their ambulatory status, and some of the other variables they use to help try to encapsulate the patients and their predicting their outcomes included things like education, psychological distress, employment status, and insurance payers. They also tried to put in surgery-specific variables to indicate whether a specific surgery would change things. This included things like anterior versus posterior approach, the number of levels in their spine surgery, whether there was a fusion, whether an interbody was placed. So after all these variables were used in a kind of multivariable analysis to create a model, each variable had a corresponding weighted factor that implied the significance or that it had in prediction. And so the top of this graph indicates more heavily weighted variables, and the bottom least less weighted variables. Interestingly, the less weighted variables ended up being diabetes, number of levels, osteoporosis, which sometimes you don't think about, maybe overemphasized. Some of the top non-modifiable factors are on the right here: employment status, the numeric rating scale, their back pain, their disability, education, workers' comp status. Top modifiable factors are their psychological distress, smoking status, and their BMI. So it kind of makes a little bit of sense. So each, there's 4 models, and they're all based on each of the basic patient-reported outcomes. So for the predictive model for the disability index, for instance, these are the factors that predicted a decreased probability of an improvement of their disability after 12 months. I highlighted some of the ones that were a little bit higher weighted, and these included dominant back pain, worse baseline disability, higher back pain scores, workers' comp, baseline motor deficit. So these kind of correspond to what we think about in terms of being poor prognostic factors and things that have been discussed in the literature for decades. And the other model for quality of life, again, some of the things that predict improvement of their quality of life at 12 months included higher education and higher pre-op leg scores. So again, things that make intuitive sense, we see in practice, and things that have been discussed for decades in the literature, they all kind of come out in this paper. And for the predictive model for back pain, same factors. And then the predictive model for their leg pain is kind of has an arrow on the left, but essentially, I just want to point out that it's interesting that arthrodesis for leg was actually a positive predictor of an improved outcome. So they had this model from this data, and so you're able to put in for any given patient, they'll give variables, and it spits out essentially what the probability for a meaningful improvement at 12 months for the different patient-reported outcomes. They have a patient A, which is a 35-year-old that essentially has good predictive variables, and patient B, as an example, a 66-year-old with poor predictive variables. And at the bottom here, you can see what those probabilities are. And for instance, the disability index for patient A has a 94.2% chance of a meaningful good outcome at 12 months versus patient B, who only has a 25.8% chance. So it's a tool. And I think that this tool, the strength of this paper and their model is that they were able to capture a large number of data points, which they were able to get from a registry. And that registry was multi-center and encompasses varied practice types. So it's applicable to different practice types, academic, private versus rural. So we see variable, which captures the fitness of their model to their data, was 0.67 to 0.69, which is reasonable, though not extremely great. Some of the weaknesses include low resolution of the surgery type. So it doesn't really capture whether for a given patient, whether MIS lateral versus MIS TLIF versus open, for instance, would be significant. There's a low number of interior surgery, so I don't know if you can really have a great enough power to actually make a determination if anterior versus posterior. It's a registry, so it has inherent low resolution and other issues. There's no control comparison, which I'll touch back on in a second. And the 12-month follow-up to me seemed rather short. I'd rather have seen 2 years, which is more commonly used in the literature. So going back to one of the disadvantages, there's no non-operative control. So you can't have a patient put in there and have 26% probability of a reasonable outcome at 12 months. You have no way of comparing that to non-operative probability. So you don't know if the non-operative probability of a good outcome in 12 months is going to be 10% or 40%. So it's not very useful to compare the two to make a decision on those two choices. I do like the idea of the shared decision making. You do spit out a number, so you make a complex issue with a lot of different moving pieces come down to something that any patient should be able to grasp with. And with that number, you can reach the subject of, say, this number can increase from 26 upwards if you were to stop smoking, if you were to lose some weight, if we were able to get some help with your psychological stress, for instance. And then one novel thing that I really liked about this paper was this concept of being able to adjust patient-reported outcomes between different practice groups. So if you have a practice and your average patient is patient A, whose predicted probability of a good outcome is 95% for the disability, and your patient-reported outcomes for your patients is 90%. Well, 90% is a pretty good number, but you're not being very optimal. You're still 5 points below what it should be. But if you're in a different group and you have a different population of patients and their predicted probability of a good outcome is 26%, but you're hitting 60%, well, that 60 may not sound as good as the 90%, but you're killing it. I mean, you're hitting 30, 35 points higher than what you should be. And I think that's a fair way of being able to look at patient-reported outcomes when you're looking at your own results, and a fair way for payers, for instance, to compare you. That's it.
Great, Patrick. Thank you very much for a nice presentation there. I certainly think it appears to be a very useful tool based on the acquisition of large data, because the pooled large data from the registry gives us statistical power in understanding or predicting outcomes based on these particular baseline characteristics. I want to ask Dr. Pate, Dr. Pate, do you think that this will affect your practice? Will you potentially consider using things like this registry or these baseline characteristics that are potentially predictive to decide which patients can have surgical intervention?
That's a question that all of us will be facing, and we're facing it now. I think we have to recognize that we are no longer the sole or the primary determining individual for a patient's candidacy for surgical intervention. Surgeons for a long period of time have been questioning when to go, when not to go, when to stop. And this type of data is going to make us realize that a great deal of our determining factors are going to be shared now with others. This paper, I think, is important because the bottom line, it talks about something that we have as physicians known for a while, the socioeconomic cascade that a patient with back pain and column pain must go through. That's the social, economic, and emotional steps, and they play a major factor in what we do. This paper recognizes, I think, that some of those factors, particularly education, having individuals that you can depend upon post-operatively, having a home to go to, and lack of fear, having something to go back to. So this type of study, these studies, not only this one, but certainly shows us we're not the primary factor of doing anything, that whole socio-economic cascade. And ladies and gentlemen, the players have been out there for a long time. We surgeons, and then you have insurance companies and attorneys, employers, and patients. So now we have an arm that we must recognize because it's a fact of life. What happens after this, we start getting into artificial intelligence and deep learning logarithms that we have to deal with.
Well, you know,
it's the first step in what we're doing. Will it affect my practice? You know, patient selection, patient selection, patient selection. It just gives me another arm in which to say, well, let's go.
But you know what? I think on the other hand, what it may do is make the, you know, the docs that are not as smart, they'll make them better doctors because we'll have the predictive analytics. They'll feed the data in, and maybe the ones that are not so perceptive, the ones that have not, you know, developed those skills, will make them better. I do agree that, you know, we're not going to be the sole decision maker. We've lost that battle a long, long time ago. And it's sort of an old art, you know, it's the old art of, you know, decision making. And we see it today, even in our area. I'm sure you see it in Arkansas. In Dallas, we have 250 spine surgeons, and they're not all A and B players. There's a lot of C and D players because they might technically be good, but they don't have the decision making capabilities of knowing who is going to, you know, be an appropriate candidate and who's not. And this way, it's a way of objectifying it. And I think this, although, you know, there's problems with the data, it is important, and it's important that we stay up with it as well.
Absolutely.
Yeah.
Those who will not do so, I think, Dr. Guy, will be in great straits because their outcomes will determine how they're going to get paid and whether or not they're going to get patients referred to them. There are organizations and big industries, whether it's Google or Amazon or Walmart, are all looking at what we're doing and our outcomes. One last thing, the days, I tell you a little, Kevin, the days of successful surgery has totally changed. If you look at the 18th century, a surgeon would say, I did a wonderful surgery. The surgery was most successful. I assure you, it was most successful. I operated, and it was a wonderful operation. But I had a very uncooperative patient. They died, and they did not appreciate my great talents. But I assure you, my surgery was perfect. Well, ladies and gentlemen, we can't do that anymore. There is data to tell us, well, maybe you should change what you're doing and think about the patients you do it on.
Yeah. Good points. All good points there. Dr. McCarthy, Rick McCarthy is our senior orthopedic surgeon at University of Arkansas. Do you think that this will affect your practice? Do you believe in large registry databases? Do you think that this will change the way you practice?
I think that as Glenn said, there's no question we have to pay attention to this data because it's the payers that are really behind doing all this large data pooling. And although we struggle to see how it's going to affect us on a day-to-day matter, such as choosing the right patient, we have to. Otherwise, as Glenn's pointed out, we're not going to get paid in the future if we don't.
Yeah, it'll be used as a weapon. There's no question. All right, in the interest of time, we're going to move on to the next journal article. Dr. Marcus Stevens, neurosurgery resident, will present his article.
All right, thanks, Dr. Kazemi. So my name is Marcus Stevens. I'm one of the PGY6 residents here at University of Arkansas. So I'll be discussing the article entitled, Does Patient Selection Account for the Perceived Cost Savings in Outpatient Spine Surgery? This was a meta-analysis of current evidence and analysis from an administrative database. And this actually came out of the group from the Mayo Clinic. Okay, so we'll get started here. So the premise of the article was that outpatient fusions, laminectomies, and discectomies have actually increased quite a bit from the years 94 to 2006. And this group hypothesized that the cost savings and the better outcomes that were associated with the outpatient cohort are actually due to patient selection, which favored the younger and the healthier patients. So what they did was a meta-analysis, and this was performed using the patient outcomes and selection factors within the outpatient spine surgery realm. And they extended this to include the ACDFs and also the LUM-LAM surgeries. And then they took it a step further, which was actually rather unique for this type of work, where they used the Vizient cost data analysis. And essentially Vizient, it's a clinical database that uses the Medicare data from large academic facilities. And they used the cost to charge ratio to determine, and they stratified this with patients' age to determine if there was actually a difference in the cost between the younger and the older patients. So after all the inclusion and exclusion criteria were applied, there were about 16 studies that were included in the meta-analysis, and they started out with over 7,500. So all of the data was actually really nicely done and put in these forest plots, and they looked at several factors. So the first factor they talked about in their study was the mean age for outpatient procedures. So they looked at several studies, and they range from an N of about 70 to 192,000 patients. What they found, which we would all somewhat expect, is that the younger patients, the patients were younger for outpatient procedures with compared to the inpatient cohorts. They looked at several comorbid conditions. The only one that they actually included and commented on was the diabetes mellitus. And for that, it's because that was the only one that showed any type of statistical significance. So they looked at diabetes and actually found that 1/3 of the patients, diabetic patients, were 1/3 less likely to undergo an outpatient procedure after all the pooled analysis was said and done with. And as you can see, with each study, with the exception of one of these of single level ACDFs, that held true even individually for the meta-analysis. So they also looked at several outcomes for inpatient versus outpatient spine surgery, the first of which was the reoperation rates between inpatient and outpatient spine surgery. And overall, after the pooled analysis was said and done with, there was a lower reoperation rate reported with the outpatient surgery group. And patients that underwent outpatient surgery were actually 60% less likely to undergo a reoperation. So if you look at the two 1-level and 2-level ACDF studies on the bottom, these actually cross 1 and go above the confidence interval at 1, which would technically make them, statistically insignificant. But there was only 1 in each group, so I think that's what that'll clarify that a little bit more. And the larger studies actually showed that the patients were less likely to undergo, outpatients were less likely to undergo a reoperation. The next outcome they looked at was 30-day readmission. And this showed a 60% reduction in odds of readmission rates in the outpatient group as well. Okay, and they also looked at the complication rates. So there was a 70% reduction after they did the pooled analysis in a patient having a complication if they underwent outpatient surgery. And two of the ones that crossed over here, one and had an odds ratio of greater than 1, there was a smaller sample size, and there were only a few that actually underwent, had a complication. The other thing interesting that they did talk about in the article was the fact that they looked at what were called major and minor complications in each one of these studies. However, they didn't report that data, so it was difficult to actually analyze that within the meta-analysis itself. So that'd be one thing that would be interesting to look at. And then lastly, and I think this was kind of the keystone of the article, was the cost analysis. So as one might imagine, the outpatient surgeries were less costly than the inpatient surgeries overall. And they looked at the direct costs with the Vizient data. And one interesting thing that they did was they looked and stratified the younger patient group and looked at that separately from the older patient group with regard to inpatient and outpatient surgery. So in the younger group, ages 30 to 35, they actually found that there wasn't a huge difference between the cost of inpatient versus outpatient surgery. It was only $555. Whereas the older group, the 65 to 70-year-old group, there was a huge difference of $7,290. And we'll kind of talk about that a little bit in just a second here. So I wanted to discuss a few things. So really the premise of the paper, patient age and patients without diabetes, that's one thing they did prove, tend to undergo outpatient spine surgery more frequently. With regard to the cost, we have to understand that age here in itself is not the actual issue here. It's an effect modifier. So patients that are more, as some would say, more seasoned or older, have more comorbid conditions. So this is more expensive to treat. They often require a longer hospitalization, and therefore it's more expensive. And that being said, the favorable outcomes tend to occur more frequently in the outpatient group for that very reason. The patients they're healthier. They have less comorbidities. It's not necessarily because they're younger. It's just what comes along with the territory of having advanced age. One thing that they didn't include here that would have been interesting to look at was the actual functional outcomes. We looked at costs, but what are the functional outcomes associated with outpatient spine surgery when compared to inpatient spine surgery, that being the ODI, NDI, and also your pain scores? Those are not included. And lastly, just one thing that we as a larger academic center one thing I was thinking about reading this, how does this data apply to us? The majority of the patients that we actually operate on are usually sicker. The age is more advanced, whereas our colleagues in the community typically have the younger, the healthier patients. So with cost being such a big driver of the healthcare industry right now, and this data coming out showing that outpatient surgery is actually cheaper and in some instances better for younger patients, how do we adjust to that as a larger academic facility? And I'll kind of leave you all with that. Thank you very much.
Thank you, Marcus. That was actually a great paper. I thought I really enjoyed thinking about that paper. I have a question. My colleague, Dr. David Bumpus, orthopedic surgeon here at University of Arkansas. David, to me, this seems to validate the fact that it makes sense to, partition or to be selective with what we do with our patients, particularly with age. Should we be doing young, healthy patients in an inpatient setting? Should we be sending them to outpatient settings which typically have been private so far? Should academic centers be investing in outpatient surgery? What is your viewpoint?
Yeah, I think more and more, just within orthopedics, the total joints tends to lead spine by a few years, but the trends I think are similar. A lot, similar invasiveness, similar patient population. So, total joints is now moving steadily towards an outpatient setting, and payers are changing their policies on that as well. So I do think we should anticipate this similar shift occurring in spine. I guess one distinction to make in looking at these types of papers is, Noojan, as we do outpatient surgery, but it's in the inpatient ORs because we don't have we don't have our spine equipment over in the outpatient side. So is it simply an outpatient discharge designation that they are using, or is it done in truly in an outpatient separated surgical center? That's one consideration. And then, definitely trying to figure out your flow. Like, how does your day work? If you have 4 cases and 2 of them are inpatient, 2 of them are outpatient, how do you arrange you as the surgeon logistically to maximize your ability to take care of those patients while not being all over town? So I think that's a question that, as we move forward, we'll really have to consider as new renovations are done and new facilities are built.
And one thing I'll say, Dr. Bumpus, to answer your question on that point, they did talk about in the introduction when they did their search query, they actually just looked at any patient that had operation date as the same as the discharge date. That was considered an outpatient procedure. So whether or not they used inpatient facilities is actually still unknown.
Right. And I think your cost savings are going to be bigger if it's a dedicated outpatient surgery center, because those are usually totally geared for efficiency, where we all know that the inpatient ORs are not. So absolutely,
yeah.
So on a national scale, within our academies, at least in orthopedics and in CMS, this is a very hot button topic, because Dr. Stevens is very correctly, and thank you, Marcus, for picking that up, that article, pointed out that there's a clear difference in terms of cost savings potentials, which has raised the interest levels of all hospital administrators and raised accusations of cherry picking. But the huge elephant in the room is the overutilization of procedures. So the general health status of the society, the societal benefit of doing these surgeries in an outpatient setting has been questioned and paired with the financial motive of those who run the surgery center. So this is a big deal. And again, the question being, are we doing more surgeries that are unnecessary rather than doing good surgeries in a more efficient setting? Thanks.
Yeah, really good point. Does anybody think that this motivates them to turn to their institution and essentially request or with data demand that a outpatient style operative setting be created for the purpose. Now we know for cost and the data needs to come on patient-reported outcomes. But is this likely to give us power to do that, or is it the flip side where they'll come to us and they'll demand that we take care of younger patients, healthier patients in a different setting to what we're comfortable with? I mean, this is I think this is an important issue.
Let me just address that, since I've switched from a state institution to a private institution a number of years ago. So outpatient surgery center is not the answer. It is surgeon-run enterprises that are tightly controlled, and we have our TBI, for instance, look at and see how this is done well, but it has to have a surgeon-directed approach. And secondly, your second part is totally spot on. Administrators, for instance, when our administrators met with us not too long ago, they want us to do outpatient SI joint fusions, and they have no understanding that we actually take care of dialysis patients and tumor patients. It's a big source of chagrin for them that we actually take care of these very sick people with horror spines. But they would love to have femonotomies done the cervical spine that are sent home within hours of the procedure. Let there be no doubt about it.
Yeah, I love that comment that it needs to be surgeon directed.
I want to make a comment about the outpatient, the inpatient, and something I think we've not hit upon here. I think you have to recognize it's the disease that has announced itself that will determine the avenue, the theater, that it should be addressed. Obviously, the outpatient environment, you won't have the A-line, you won't have the monitoring, you have a quicker turnover time, the patient will have a weight that's more acceptable, they will not have an overload of fat that one will have to address in the inpatient setting. But do not forget, it is the disease that is a driving factor here. It's not whether you go outpatient, inpatient. Obviously, the younger individual will be less burdened. But if the disease announces itself in a fashion that it cannot be ignored, then the theater of choice will be determined. The disease still drives us, ladies and gentlemen, not just all statistics. We have to be careful with that, because I remember Mark Twain, when you talk about statistics, he talked about there are lies, and there are lies, and then there are damn statistics. So be cautious. Remember, the disease is a factor on which we will base the roadway to travel.
We're very fortunate. Dr. Pate always has words of wisdom for us, and that's another example. Thank you. I love that. Statistics and lies. Okay, so in the interest of time, let's move on to the third article. Dr. Natalie Gooley, neurosurgery resident, present another article on the theme, alongside the theme of patient selection. Thank you, Natalie.
Hey, thank you. And so I'm Natalie Gooley. I'm a neurosurgery resident at UAMS. Today I'm going to talk about the paper, the MIS Step2 algorithm, an updated algorithm for patient selection in minimally invasive deformity surgery from JNS Spine. So this paper is based off of an algorithm that was originally created some time ago that was designed to act as a tool for clinical decision making when considering adult spinal deformity correction, specifically to guide a clinician as to whether the pathologies might be addressed with MIS or traditional open techniques. So you can see here the original MIS-DEF algorithm that resulted in categorization of one of three classes. The first two classes being pathologies which would be addressed with MIS surgery, and the final which would require being addressed with a traditional open approach. The authors felt that given the significant advances in MIS technology and the greater number of pathologies that it could now address, that there warranted revision of the previous algorithm. So in order to do this, they did a modified Delphi technique, which basically is an iterative survey method where they take a number of experts from the field and survey them, and eventually they converge on a number of factors that they felt were the most important when compiling the algorithm. And the primary goal of this paper was to gauge the reliability, the observer reliability of this algorithm. In order to do this, they did a survey of 14 fellowship trained spine surgeons. They represented all walks of practice, from, 1 year out of training all the way to 14 plus years out of training, and trained in traditional techniques, traditional open techniques, or MIS. They were, chosen to represent a range of individuals practicing. They sent each of these surgeons 24 cases, which the surgeon then ran through the algorithm and categorized themselves. 2 months later, they were then resent the same cases, which the surgeons then re-rated as well. And then statistics were run in order to determine the observer reliability. So you can see here the new MIS-DEV2 updated algorithm, and the number of preoperative factors that they assessed. The factors being whether the primary branch point being whether it's a fixed or a flexible deformity. They also looked at sagittal vertical axis, pelvic tilt, lumbar lordosis, pelvic incidence mismatch, and coronal Cobb angle. You can see this algorithm results in one of 4 categories, the first 3 of which are pathologies that could be addressed with MIS techniques, and the final of which would require a more traditional open technique. And you can see here that if you do have a fixed or rigid deformity, which they gauged based off of change in supine versus standing x-rays. So if you have a rigid deformity, you're kind of automatically now pushed in these latter 2 cases, the latter 2 classes, as it were. And the authors did specify that class 3 is kind of a particular kind of borderline area, which required more complex MIS techniques, and the authors qualified probably were really only appropriate for more experienced MIS surgeons. So these are the cases that they chose in the paper to represent each of the classes that were described. And so I just wanted to briefly go through them one by one. So you can see in class 1, this case has good sagittal alignment. They do have a focal kind of mild scoliosis of the lumbar spine. And this particular case was addressed with a minimally invasive decompression. Class 2 is pretty similar to class 1 in that it has good sagittal and relatively decent coronal balance, but has a more severe focal scoliosis of the lumbar spine. Class 3 is a more significant deformity with more kyphotic deformity of the lumbar spine, some sagittal imbalance, and also some mild coronal imbalance as well. And this was the class that required a more complex approach and instrumentation as well. And then finally in class 4, this patient has very severe sagittal imbalance and a coronal imbalance, as well as previous instrumentation, which required revision and a traditional open approach. In the end, they looked at the kappa statistics to determine the reliability of the both intra-observer and inter-observer reliability. So in terms of the intra-observer reliability, it was very high for a majority of the surgeons. 11 of 14 were a kappa of 0.8 or higher. There were 2 surgeons that had low reliability, meaning that they did not reliably rate the cases between round 1 and round 2 in the same category, and then 1 that was borderline. Whereas the inter-observer reliability was very high for rounds 1 and 2, both above 0.85. And there were, in fact, 7 of the 14 surgeons that agreed completely on their categorization of all 24 cases. So overall, in conclusion, this paper, I think, identified an algorithm, a new updated algorithm that more completely demonstrates the wide variety of pathologies that can now be addressed with more advanced MIS techniques, including addressing more significant sagittal and coronal imbalances. So this is a good, potentially reliable and reproducible clinical tool, which could be used to guide intervention of, spine surgeons. And that's it.
Thank you, Natalie. That's definitely an interesting paper. For me, it's nominally it appears to focus on inter-observer reliability between surgeons and say that different surgeons agree that deformity can be treated MIS in some cases, and there are severe cases where it can't be. But in reality, I think it's kind of pointing to the fact that there is a cohort of surgeons now that feels that a lot of the open techniques that were previously maximally invasive and had all of the issues with traditional open surgery can be done in a more MIS way. I mean, that's kind of the hidden message that I read from that. And this is not necessarily new. It's been around for a while. We've tried to categorize patients into categories based on spinal pelvic parameters and so on. Dr. Chapman, I'm keen as somebody who's seen the evolution of spinal deformity surgery from always traditionally open to now more and more MIS techniques. Do you agree with this? Do you think that it's an oversimplification? Do you have comments to make about its real utility, actually?
Yeah, so thank you for inviting me to comment on this interesting article, and thank you for selecting this again. All great articles. So the main issue with MIS is still longitudinal follow-up, and do we actually improve patient outcomes? There are significant ups and downs. I'm personally absolutely not sure that we're ready to have an algorithm tell us what patient does better with which deformity. I think this is very premature, and the selection criteria applied are very monofocal on the type of deformity. They do not take the patient body habitus, the multiple variables that we're facing in a patient into play. I'm sitting here next to the good Dr. Oskuyan, and I'll pass the microphone to him. I think I'm seeing a beginning nod from him. The number of complications that we see in our very select practices from deformity surgeries is profound, and especially MIS surgeries where there's hardware loose and floating around and the premises is pretty substantial. So not all black or white, but there are gray zones that I think we need to articulate here.
Great point, thank you.
Yeah, I mean, I agree, Nooj. I think, again, what's the definition of MIS? Is lateral surgery considered MIS? And I think, going back to what everyone kind of commented on, it's like the same, it's the pathology is what drives what we do. It shouldn't be that we try to fit the procedure for the patient.
Yeah.
And I think, again, I mean, I did a lot of MIS surgery. I still do a lot of MIS surgery. I don't really call it MIS surgery. But I think, we have to be really careful, especially now, when you look, for example, the great articles that were just presented, these are adult patients who we all know, it's not all about spinal balance. They have lots of comorbidities, they have bone quality, they're oftentimes obese, and in my practice, those are the worst patients to do MIS surgery on. They're not fused. So I think, I think we just have to be careful about trying to brand or rebrand or bundle things and say, we're doing something because it's minimally invasive or cool or slick. I think pathology is really the driving factor in a lot of this.
Yeah, really good point. Yeah, I love the comment that we should be driven by pathology, not by the latest technique that somebody has come up with, or some new tool that we add to our armamentarium. Dave Bumpus, do you not think though that it's still useful? It's still a useful exercise to kind of categorize, deformity from degen, adult degen, simpler deformity to all the way to fixed deformities, and kind of use this as a rough guide to consider the different operative kind of tools that you have? I mean, will this ever be useful for you in your practice, do you think?
Yeah, absolutely. I mean, I think the exercise is very helpful to sort of organize where the leaders in the field are, you know, what direction they're thinking, and but that algorithm needs to then be tested with, you know, with clinical validation.
Yeah, absolutely.
So, you know, how many, you know, years from now collect outcomes, you know, however many patients, you know, where that algorithm was followed, and then, you know, how many surgeries went according to plan, how many met their goal parameters, what were the operative complications, et cetera. And, you know, the other thing that I would offer on that paper is that I do think that just simply trying to get PI-LL mismatched less than 10 degrees in either direction of neutral is probably antiquated as well. I think the gap score algorithm in my practice is proving to be really useful and integrates a more global perspective on achieving a target alignment, and it also integrates the age of the patient. Bone quality, I think, is something that needs to be integrated into this as well. You know, you can be much more aggressive, obviously, with your corrections in people with normal bone quality rather than severe osteoporosis. So 100% we need these types of algorithms to guide further thought, but I wouldn't take it as gospel truth.
Yeah.
But I do like that they, you know, these expandable implants are really quite fantastic for a lot of these sagittal deformities, and updating these algorithms to keep pace with the implants, I think is important. So I applaud the authors in that respect.
Yeah, I love the fact that they thought of that. I mean, remember the paper was really focused on whether the surgeons agreed between themselves as to what, you know, surgical techniques could be applied to what. And it's interesting, you know, there's probably more agreement than not, which is surprising for us as a spine surgical community. But as many of the panelists have kind of pointed out, the MIS, call it whatever you want, you know, however which way you define it, it's always the right surgery for the right patient, you know, under the right circumstances with the right surgeon. You know, when you have a marriage of all those components, you have a good outcome, or at least a chance of a better outcome, I think. Okay, thank you. We'll move on to the last article now by Dr. Matthew Helton, resident in neurosurgery resident. Thank you, Matthew.
Okay, my name is Matthew Helton. I'm a PGY4 resident here at University of Arkansas for Medical Sciences. Today, with our patient selection theme, I will be talking about a paper from J&S Spine in 2019 entitled Predicting Non-Routine Discharge After Elective Spine Surgery, External Validation of Machine Learning Algorithms. This paper is written by a group from Brigham and Women's Hospital in Boston, as well as Leiden University in the Netherlands. So this is an external validation of a machine learning algorithm they had published the year prior in 2018 in Neurosurgical Focus, where they tried a variety of different machine learning algorithms and came up with the best one at predicting whether or not a patient was discharged home or a non-routine manner, which means either a rehab facility or a subacute nursing facility after having a surgery for a lumbar degenerative disc disorder. Okay, so a little bit about machine learning. It's, you know, kind of this hot new topic for us in the medical community. So you take input variables, and these input variables in this case could include age, sex, BMI, presence of diabetes preoperatively, how many fusions, what levels of surgery, so forth. And then these input variables are put into functions with different weight, which lead to these nodes. Now these nodes are then put through an activation function, which then activates certain nodes to give you eventually an output. And this output, in this case, is the probability the patient is discharged to home or discharged to a rehab facility. Now, this whole process is called forward propagation. Now, initially, these probabilities are not based on anything, and so they're going to be way off. And so what you have to do is measure the error. So you have to measure the actuality that the patient was discharged home versus the probability that they would be discharged home. And this gives you a high amount of error initially, and then through trial and error, in this process called back propagation, the computer actually adjusts the different weights of the functions to give you the least amount of error possible and give you a solid algorithm in order to have a higher probability, or have a less error and a greater degree of knowledge going into how the patient's outcome is going to be. So as a background for this, value-based care is becoming more important, decreasing costs and hospitalization. Certainly, as Dr. Pate mentioned at the beginning, deterministic versus probabilistic methods are, as we move more towards a probability-based system where we need to know what the patient is going to require postoperatively to decrease the hospitalization. And lumbar degenerative disc disorder is the most common indication for elective spine surgery. And then the non-routine discharge, which is discharged to a place other than home rate, is about 9 to 19%. So 9 to 19% of our patients a lot of times sit in the hospital waiting for a rehab bed to open up before they can go to it. So that's going to cost, keeping them in the hospital for several days can cost not only money, but also it can increase their risk of developing things like pneumonia and UTIs. So the methods for this study, they externally validated a machine learning algorithm they developed from the National Surgery Quality Improvement Program big data set. This was 27,000 patients that they, from this set, that they trained their algorithm on 80% of it, and then 20% of it, they internally validated it. And that was the paper from 2018 they published. So this study is a retrospective cohort from 2013 to 2015 at a single center, which externally validates that original machine learning algorithm. And below you can see the inclusion and exclusion criteria. The primary outcome being home versus non-routine discharge, which again is discharge to a place that is not home, including rehab facility or subacute nursing facility. The input variables determined by the prior algorithm include age, sex, BMI, ASA score, functional status, meaning independent or dependent, number of levels, 1 or 2 levels versus 3 or more levels, whether or not the patient had a fusion, history of diabetes, and preoperative hematocrit level. So baseline characteristics of the study population, there was 144 patients, and you can see these patients were involved in this institution's transitional care program, which was a program to ensure optimal preoperative health, along with plans for discharge postoperatively, including ensuring that they had caregivers at home to help care for them. And so what that results in is you only see a 7% non-home discharge rate in this population. So relatively healthy population compared to a lot of other populations that we see. So this algorithm using this externally validated set shows that it has a very high C statistic, meaning a high sensitivity without having to sacrifice a lot of specificity to achieve that. And, you looked at Dr. Paulus's first paper, his C statistic was 0.67 to 0.69 for that algorithm. And this computer learning or machine learning algorithm achieves 0.89, which is extraordinary. And then looking at the calibration plot of the neural network, you see that the predicted probability matches up well with the observed proportion. The red line is perfection. The gray is the 95% confidence interval. And you can see our calibration slope is 1.09. And the intercept is negative 0.08, which shows as well calibrated. The Breyer score, which in a unidimensional analysis is equivalent to the mean squared error, is only 0.049, so very, very low error. So the algorithm depends on the clinician's tolerance to risk. So as you can see on table 2, at a threshold of 25% prediction of patients going home, the algorithm can accurately predict that patients going home 97% of the time. So when the algorithm says this patient is going to be discharged home. 97% of those patients get discharged home. So that leads to only 3% of patients that are left in the hospital that do not have a rehab bed, who you're waiting on, insurance clearance and a rehab bed to open up. Whereas if you look at the prediction of non-home discharge, the algorithm is less poor, and is more poor, but that's because of the threshold is set at 0.25. So the prediction of non-home discharge in this case, 50% of patients that they say will have to go to a rehab facility actually end up being discharged home. So that means that you're wasting some social work preoperatively, but you're ensuring that the patients that need rehab will go to a rehab facility without having to sit in the hospital and accumulate extra hospital length of stay. And you can see that the model outperforms two different kind of methods. One method being the all method, meaning you obtain a rehab bed for all of your patients. And you can see that as the cost to benefit ratio lessens, as basically the social work bill increases compared to the length of stay bill, you very quickly becomes a negative benefit. Now, and then the other option is to say, none of our patients will need rehab beds. And then you can see that the model, once again, outperforms that as well and has an increased net benefit. So the pros of this study, it's the externally validated, highly accurate model, and is practical based on the benefit cost analysis curve. But the cons are it's a small sample size, it's retrospective, it's a relatively healthy population that they externally validate it with. And it's theoretical and kind of difficult to understand, but at the end, I think it's a very accurate algorithm, and I think it can improve performance and value-based care at our institution and help predict patient and help us to obtain rehab beds for patients who need them preoperatively, so they don't have to sit in the hospital and increase our length of stay and increase the cost and increase the risk to them to developing other diseases that are related to this length of stay. And so in that, any thoughts or questions?
Thank you, Matthew. I actually really enjoyed that paper. You may argue that the cohort of patients was too healthy, or they didn't pick enough of the correct characteristics or patient factors to enter into the machine learning algorithm, but I really believe this is probably the future, both for us, but payers and insurance companies using this to predict outcomes and suitability for surgery. I want to hear from our Texas Back Institute masters as to their opinions. Dr. Lieberman, what are your thoughts? I mean, you think there's something in this?
Oh, there absolutely is. Numbers, knowledge, power, that all adds to this and is going to help decide what to do. My big fear, though, is we are going to lose sight of patients, and we're going to lose sight of how we have to take care of people. Numbers tell you a lot, but not quite everything. So this is all good information in terms of predicting what's going to happen. But we all know we can predict, but nature still turns around to remind us who's in charge.
Yeah, I agree with that. I guess it says that we can better predict. Nature will always intervene, but we can get better at the game. Dr. Guy, do you have any thoughts? Is this something, at some point you're going to turn around and say, hey, I need to, know what's going to happen to this patient? Show me the output from the machine, Tell me what this patient will do.
Well, I agree with Izzy. It's, data is very, very powerful, but, and things are changing. So in the future, I think it's going to be very, very different. I think that, data is knowledge, and it's going to change the way we do things. One of our old fellows posted a little note on the side there talking about how, we used to do open rotator cuff repairs, and now that's almost never done 20 years later. So I think we're going to see big changes in the way we do things and how we decide to do them.
Yeah,
I mean, we're not there yet. We're not there yet.
Yeah. Okay, well, thank you very much. I enjoyed those papers. Thank you very much for inviting University of Arkansas to be involved in the Virtual Journal Club, and we're honored to have participated. Thank you.
Well, listen, you all did a great job, and it was very interesting articles and good discussions. So everybody stay safe and have a great weekend.
Thank you.
Thanks,
Take care.
everyone.
Have a good weekend,
Thank you,
everybody.
you too.
Thanks for watching. Hit the subscribe button for more medical content.